Thank you very much for the invitation to present during this conference on a very important topic, respiratory effort, not too high, not too low. So these are my disclosures, nothing really related to the current presentation. And these are the topics I would like to discuss in the next 15 minutes or so. So a little bit of a background on respiratory drive and effort. How can we assess the respiratory drive and effort, and how can we control respiratory drive? So this slide gives a nice overview of the anatomy of respiratory drive. The origin of respiratory drive lies in the respiratory centers in the brainstem. And there are different centers for inspiratory and expiratory muscle activity. There are actually three major pathways that affect the activity of the respiratory centers. The most important one is the chemoreceptors. Chemoreceptors that are sensitive to changes in pH, in arterial blood, or more precise, in cerebral spinal fluid. A little decrease in pH has a very strong influence on the activity of the respiratory centers. The second pathway after chemoreception is the mechano and irritant receptors in the chest wall, in the respiratory muscles, and the alveoli. For instance, alveolar stretch inhibits inspiration and stimulates expiration through the well-known Herring-Breuer reflex. And the third influence in respiratory centers are from the higher cortical centers. Damage to the cortex usually increases activity of the respiratory centers, but it also allows you to voluntarily control breathing. And if you're interested in this topic, I can recommend you our recent paper on critical care, or if you're really interested and want to go into depth, there's a fantastic paper in Nature Review on this topic. So that was the respiratory centers, and the output of the respiratory centers are the respiratory muscles or the respiratory pump that generate effort. So there's a difference between respiratory drive and respiratory drive, the output of the respiratory centers, and respiratory effort, the output of the respiratory pump. And it's known that both low and high respiratory drive and effort may have detrimental effects. So low effort is associated with respiratory muscle atrophy, patient ventilator dysynchrony, and sleep fragmentation, while on the other hand, a high effort may result in lung injury, diaphragm injury, may have hemodynamic consequences, and may result in dyspnea sensation. So this is a very famous picture describing self-inflicted lung injury published in the Blue Journal 4 years ago. So in a patient with lung injury, for instance pneumonia, capillary leak will develop, resulting in lung edema. Lung edema impairs gas exchange, but also triggers the receptors in the lung, which increases the irritant receptors, which increases respiratory drive. The increased respiratory drive results in increased effort, and high effort of the respiratory muscles may result in high lung stress and strain, development of Penderluft, and so on, that further exacerbate lung injury and capillary leak. But effort has also an impact on the diaphragm. So let's focus on this. Mechanical ventilation. High levels of inspiratory cyst may completely abolish activity of the diaphragm that may result in disuse atrophy and weakness. But on the other hand, in a patient on assisted mode, insufficient unloading of the diaphragm may result in load-induced injury and such diaphragm weakness as well. So this is a very famous picture published in the New England Journal of Medicine a couple of years ago, where Levine demonstrated that even short periods of disuse result in atrophy of the diaphragm. But this was in brain-dead patients. So these are data from real ICU patients, and indeed we could demonstrate atrophy of respiratory muscles in critically ill patients compared to healthy controls. But interestingly, we also found infiltration of inflammatory cells in the diaphragm of ICU patients. And even more interestingly, there were structural modifications in the diaphragm. So right here, you recognize the diaphragm of a healthy subject. You recognize the striation pattern, typical of a muscle. But this is a biopsy of a patient on the ventilator. And the large areas of injury where the complete striation is actually lost. And this is called sarcomeric disruption, which is not consistent with disuse atrophy, but more with load-induced injury. So diaphragm protective ventilation means that we want to avoid low breathing effort and high breathing effort, or maintain breathing effort within the physiological range. Again, high and low effort may have a negative impact on the diaphragm and the lung. So there is a strong rationale to monitor respiratory drive and effort. And there are different techniques available, but I have discussed this in a separate presentation, a separate video on demand. So if you are interested, I can recommend you to review that specific video. The state-of-the-art technique is esophageal pressure monitoring, but more non-invasive techniques may give a reasonable estimation of respiratory drive or effort. In the Blue Journal publication, we have provided some guidance for reference values to prevent disuse atrophy of the diaphragm or load-induced injury, but it is important to keep in mind that the reference values are still subject of debate. These are based on physiology and consensus, but mostly not on very strong clinical evidence. Okay, let's focus a little bit more on the clinical implications of lung and diaphragm protective ventilation, or the clinical implications of high or low effort. So it is important to minimize stress and strain to protect the lung. So prevent excessive inspiratory assist, either delivered by the ventilator or because of the high drive or effort of the patient. This results in high stress and strain, Pendeluft, and other mechanisms that may result in lung and diaphragm injury. So if respiratory drive is too high or too low, how can we modulate drive? So let's go back to the anatomy. There's actually three ways how we can modulate respiratory drive by controlling emotion and behavior, chemoreceptors, or the mechano and irritant receptors. And that is what we have shown in this figure. So cortical stimuli obviously can be modulated by sedation. More sedation reduces the input from the cortical stimuli, reduces activity of the respiratory centers. It also reduces the chemoreceptive stimuli. The body becomes less responsive to increases in CO2 or decreases in pH. Changing inspiratory assist may have an effect on chemoreceptor stimuli and mechanical stimuli, and setting of PEEP also has an effect on respiratory drive, but I don't have too much time to go into detail. And more invasive, or I would say perhaps more experimental, changing pH can be done with extracorporeal CO2 removal or ECMO. So modulating the input of the respiratory centers affect respiratory drive, which affect the output of the respiratory centers, and such modulate respiratory effort. This decreases the risk of dynamic lung stress and diaphragm atrophy and injury. So I think it's important to focus a little bit on the effect of the modulation of inspiratory assist. How does it affect respiratory drive? So this is a study we published a couple of years ago. Patients on 12 of pressure support, tidal volumes, 10 ml per kilogram. Reducing inspiratory assist to 6 centimeters of water only has a limited effect on tidal volume. As you can see here, it decreases from a little bit above 9 to 9 ml per kilogram. But reducing inspiratory assist has a strong effect on respiratory drive, right here quantified with electrical activity of the diaphragm. And because of the increase of respiratory drive, the transpulmonary pressure, the damaging pressure applied to the lung, does not change. So despite the fact that we have decreased inspiratory assist, transpulmonary pressure remained the same because of the upregulation of drive. At the same time, of course, an increase in drive increases breathing effort, so increases the work of breathing to potentially injurious levels. So we can modulate drive with sedatives, but it's important to realize that different types of sedatives have different effects on respiratory drive. In general, benzodiazepines and propofol decrease the amplitude of effort. In general, do not have much effect initially or increase respiratory rate, and only at very high dose decreases respiratory rates. On the other hand, opioids increase the amplitude of respiratory drive, so increase tidal volume, but decrease respiratory rate. While on the other hand, dexmedetomidine has little effect on respiratory drive and respiratory rate. I skip this for the interest of time, but if you are interested in this topic of modulation of respiratory effort and drive, on modulation of the impact of high and low drive, and strategies to improve, to control respiratory drive, I can highly recommend you to read these two papers that we recently published in Intensive Care Medicine and the Blue Journal. So to conclude, what I've shown you in the last 15 minutes is that high breathing effort is associated with lung stress and strain and diaphragm injury, but it's also important to keep in mind that low breathing effort results in diaphragm atrophy and may result in atelectasis. So there is a rationale to use bedside techniques to monitor effort. State-of-the-art technique is esophageal pressure monitoring. There are more non-invasive techniques available, and again, I refer you to another video on demand. And modulation of respiratory drive and effort, changing ventilatory assist, modulation of sedation, and more experimental CO2 removal. Thank you very much for your attention.